Hello, everyone, and welcome to March's Adult AML Chapter event brought to you by the HealthTree Community for AML program. My name is Katie Braswell, and I'm the HealthTree for AML Community Director. I'm very grateful to have each of you here for our meeting today and for your support in building this adult AML community. I'd like to let you know that today's session will be recorded, and the recording, along with the slides and any resources we discuss today, will be sent via email to all registrants within 48 hours after the event has concluded. Here's a quick rundown of the Zoom features you will need to know about for today's event. If you hover over the bottom of your Zoom screen, you will see a row of icons appear. To turn on your video, you'll press the Start Video button and press it again in order to turn your video off. We would love for you all to keep your cameras on if you feel comfortable. Doing so helps to create a stronger sense of community. Each of your microphones should be muted and will be kept off by our team throughout most of the event. You may unmute yourself during our discussion time at the end. Press the chat icon to open up the chat box. If you have any questions or comments for us or for our speaker throughout his presentation, please type them here. And lastly, if you would like to verbally ask a question or make a comment during our discussion session, you will click on reactions and then the raise hand option. We will review all of this again after Dr. Hantel's presentation. And now let's get started with today's event. First, I'd like to thank our sponsors, without whom this event would not be possible: Bristol Myers Squibb, Amgen, Genentech, AbbVie, and Jazz Pharmaceuticals. The topic of our event today is titled Working to Overcome Health Disparities in AML. Here's the agenda for today. I will introduce our speaker, Dr. Andrew Hantel, and he will spend the next 30 minutes or so giving us his presentation. After the presentation, we will open it up for your questions and comments and end the event with a few announcements. So let me take a second to introduce our speaker, Dr. Andrew Hantel. Dr. Hantel graduated from Loyola University, Chicago Stritch School of Medicine in 2013 and received internal medicine residency in hematology, oncology, and medical ethics fellowship training at the University of Chicago. He is now a hospitalist in medical oncology and an ethics consultant at Dana-Farber Cancer Institute, as well as an instructor in medicine for Harvard Medical School. Dr. Hantel's research focuses on investigating and advancing ethical issues of scarce resource allocation in hematology oncology through patient-centered health services research methods. We are so honored to have you here with us today, Dr. Hantel, and are extremely grateful for the important work you are doing on investigating racial ethnic disparities among those with AML. And so with that, I'll let you go ahead and get started.
All right, you can hear and see me okay?
Yes.
Great. All right, let me share my screen. Might take 1 second here. Okay, and you can see full screen?
Yep, looks great.
Wonderful. All right, well, thanks again for having me, and thanks everybody for attending. So you already heard the title today, so we can move on. I just want to make sure to say that I don't have any relevant financial relationships to disclose, and won't be talking about any off-label use or investigational use of medications during the presentation. And just for a short outline of what we'll be going through, I've kind of divided the talk into 3 sections. First, we'll define what health disparities and equity are. Then we'll review some literature about the health disparities and equity in AML. And finally, we'll discuss how and why this matters for patients. But even before I kind of get to that talk, I should point out that there's kind of an unavoidable tension in my research in that I'm a white, straight, cisgender male from the Midwest who doesn't have a lot of personal experience being subject to health disparities or discrimination in most of its forms. So my role and kind of goal in this work is to be an effective ally, working in solidarity and collective action on systems of inequality, and not, quote unquote, saving those less fortunate. I think it's my obligation as somebody with these unearned privileges to redress the social structures that cause and perpetuate advantage and disadvantage. And today's talk is a small part of that work. So moving to the first part, our definitions. So first, what is a health disparity? And I think it's important to review these terms because for a long time, the ones that we had were somewhat inaccurate, and using the correct terms and definitions ensures that we're talking about this area of research and healthcare in an encompassing and structured manner. So health disparity, according to Healthy People 2020, which is a federal program that sets data-driven national objectives to improve health and well-being over the decade, is a particular type of health difference that is closely linked with economic, social, or environmental disadvantage. And in this definition, economic disadvantage refers to a lack of material resources and opportunities, for example, low income or lack of wealth, and the consequent inability to purchase goods, services, and influence. Social disadvantage is a broader concept. While it includes some of the aspects of economic disadvantage, it also refers more generally to someone's relative position in a social pecking order. And finally, environmental disadvantage refers literally to the environment in which somebody lives, such as residing in a neighborhood where there's concentrated poverty or social disadvantages that often accompany that. Now, discussed in the second quote, health disparities adversely affect groups of people who have systematically experienced greater social or economic obstacles to health based on all of these different groupings labeled in bold. There are a number of these groups, and I think they're listed out separately, but the big thing to note is that these groups are really never separate. We all are part of many, in each subgroup of one of these, and a lot of the time people have intersections where they are part of a minority or disadvantaged part of each of those groups, and have intersectionality where health disparities are really additive or multiplicative when people are part of different groups that have been disadvantaged over our history. And so next, moving on to what are social determinants of health. This is within the definition of health disparity, and the idea of social determinants are the conditions and the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. And the 5 areas that you see on the right are one way to categorize social determinants and help us think about how they impact health and well-being. And they are listed out as education, access, and quality, economic stability, social and community context, neighborhood and built environment, and finally, healthcare access and quality. And as you can see, healthcare is labeled as one of these categories, but they all interact with each other such that changes in one area can lead to differences in experiences and outcomes in healthcare, like a lack of economic stability affecting healthcare access, for instance. And finally, what is health equity? Health equity is a term that brings together this idea of health disparity and social determinants of health together. And it's defined as the principle underlying a commitment to reduce and ultimately eliminate disparities in health and its determinants, including social determinants. And so what is the basis for these statements, or more specifically, what is the basis for singling out a certain category as health differences, such as those linked with economic, social, environmental disadvantage for special attention? There's 2 main reasons. First is that past interventions have shown that economic and social disadvantage can be reduced through social policy targeted interventions. And second, as we'll review in a second, for AML, a growing body of evidence strongly links economic, social, and environmental disadvantage with avoidable illness, disability, suffering, and premature death. And these are the longstanding goals of the health professions to minimize these outcomes. So getting into the data on disparities in AML. This is a very simple diagram that I have coined as the association to action spectrum, within which we can frame our questions about AML disparities. The definitions we just spoke of discuss disparities as differences that impact certain groups of people. So those initial questions are those of identification, and those are the ones that you see on the left here. Which people or what groups experience AML-related disparities, where and when are they experienced, what disparities do they experience, and what is the degree or the severity of the disparity. And after we look through those questions, we have a slightly more existential question that needs to be answered, which is why do these groups experience these disparities? And more granularly, and from the standpoint of trying to reduce and eventually eliminate them, we can analogously ask what determinants cause these disparities. And then finally, we can come more to the action question. How are these disparities perpetuated, and how can we intervene to reduce and eliminate them? And each of these questions encompasses huge areas of research into themselves, but I think this helps set the stage as we think about what we know so far and where we need to go in acute myeloid leukemia. We'll start at the left side of that spectrum and describe the outcome disparities that have been shown in AML. And the only last thing I should note is that since this is not a cancer like lung or breast cancer, where there are evidence-based screening recommendations like for mammograms or colonoscopies, we don't have any evidence of disparities in cancer detection for AML. So our associations that we're talking about today are generally around treatment and outcomes, but not screening or diagnosis. So there have been a number of large database analyses looking at disparities in survival for persons diagnosed with AML. This first analysis used data from patients across the country. As you can see on the left here, it was from around 1999 to 2008 that these data came from. And it looked at kind of disparities based on those general demographic groupings that I spoke about a little while ago. So it took a look and saw how there were relative decreases in survival 5 years after diagnosis between two groups. And the group that we're looking at and we're saying there's a relative decrease for is the one that'll be here, and then kind of the comparator group, the one that they're saying it is lower compared to, it will be kind of in the parentheses here. So you can see that men compared to women have about a 4% decreased survival after 5 years. There's a lot of, or a significantly lower survival as people get lower with AML. So with the group of children and those less than 21 years as kind of the reference group, as people get older, there's progressively less survival with 5 years after diagnosis. And obviously these numbers are a lot bigger than something like 4%, but that is more because we actually have such good treatments for pediatric AML that the vast majority and percentage of children can be effectively cured nowadays, which unfortunately is not yet the case for adults. And that's largely because we can give them a lot more intensive therapy, and actually the biology of pediatric AML is quite different from that for adults. And then finally, we can look at race and ethnic disparities. This was just looking at several of the larger groups, and so they were able to look at African-American Black patients versus white patients, and Hispanic patients versus white patients, showing that they also had decreased survival after 5 years by 12% and 6% respectively. And this doesn't really tell us why or how survival differs between men and women. We know some of the things that I just mentioned about why survival differences by age, but not as much about why race and ethnic disparities exist, at least from these data. So we'll kind of get into that shortly. This next study kind of added another layer to those general associations that I showed by asking the question, how has survival changed over the last 40 years, and has it changed similarly for all race ethnic groups? And this chart shows you what are changes in 5-year survival for people identifying as white, Black, Hispanic, and other race ethnicities over 5 decades. So they're comparing each of these time periods that you'll see listed off on the left for these groups compared to the 1970s. And if we show you trends that are going to the right like this, that means that survival would be getting worse as you're going from people who are diagnosed in the 80s to the 90s to the 2000s to the 2010s. If we showed an arrow that was going straight up, that means that survival really didn't improve for people. And trends going to the left in green, like you can actually see happening for each of these groups, means that survival is improving over time as our treatments and supportive care is getting better. And next to each of these, I've shown the percentage improvement in survival for each group, comparing this 2010 point here compared to the 1970s. And so you can see that compared to, if you compare kind of each of these percentages to white folks here, that there's only a 39% versus a 47% improvement in survival for patients who are Black, 43% for those who are Hispanic, and then 49% for this large group that was grouped as other. And that I've just highlighted these in red and green because of the lower improvements for these groups and the higher for this group. And I should also note that these are relative improvements. So if you remember from the last slide, there were also kind of absolute differences in survival. And there's also, as you can see, kind of differences in the improvements in survival that are lower for Black and Hispanic patients compared to white patients. And then finally, there's this analysis of 7 trials that enrolled over 2,500 patients and began to look at what other important outcomes might correlate with survival disparities by race. And in these trials, and unlike those real world data that I showed you on the previous two slides that were from large databases that they looked at patients across the country, we know that everybody on that's part of this data got the same treatment on those trials. So the differences in these outcomes weren't affected by potential differences in treatment access, which is an important part of health disparities, but this allows us to kind of control for that and look at other differences. Importantly, as you can see, there were still differences here between different races and sexes. So in the chart here, this is kind of the proportion or the percentage of people surviving, with 1 being 100% and 0 being 0%. As you go out from kind of the time of enrollment on the trial over years up to 6 years. And you can see here that this is a label for white female, white male, African-American female, and African-American male. And I've just drawn some lines here that are kind of showing the differences between the white and African-American sexes, as you can see. And so even when accounting for kind of the treatment being the same, you can see that over time, there were differences mainly based on race for these groups, and also between the sexes. Again, these data don't really move us past that association phase, but they give kind of a slightly bigger picture of how we arrive at disparate survival outcomes and disparities that might be due to both differences in treatment as well as these other factors that happen when they're controlling for differences in treatment. These things on the left are what are called interim or surrogate outcomes, and it shows that apart from the survival that I'm showing on the right, that African-American men also had lower rates of complete remission, meaning disappearance of their leukemia after the treatment, at 54 versus 64% compared to all other groups, and that disease-free survival for African-American men and women were around 26 and 21% respectively. So from these data, we can start to answer some of these questions, like who experiences outcome disparities in AML. And from what I've just shown you, there's Black, Hispanic, and elderly patients with acute leukemia, as well as in some cases men who have worse outcomes that are disparately worse. And I will note that these are far from the only groups that experience AML outcome disparities, but I just wanted to present data within this framework to kind of show you how we can move from that association to action spectrum. So I'll kind of keep the statements here focused on the data that I'm presenting. And we know that they experienced lower rates of remission, survival, and survival improvement based on what I just showed you. And we know on aggregate that these groups experience outcome disparities in the United States and as recently as the 2010s. So next we have to think about what determinants cause these disparities, how do they perpetuate them, and what interventions have been attempted to reduce them, and eventually, which we haven't got a lot of data on yet, what parts of interventions actually work. And as we move from the who to the why and how, we can also start to categorize what might lead to AML disparities from our knowledge of health disparities more generally. This 4-box model separates potential underlying reasons for disparities in outcomes by biologic factors, such as differences in the metabolism, kind of how quickly people's livers and kidneys and the rest of their organs kind of deal with the chemotherapy and other drugs that we give them to treat the leukemia, as well as differences in tumor biology. Like was shown in the video, there's a variety of mutations that people can have that we'll talk about in a little bit that can make their leukemia more or less likely to respond to treatment. And then there's also health behaviors. So, we know that some groups, and we'll get to this in a little bit as well, have decreased enrollment on clinical trials, as well as more therapies for leukemia are becoming oral, people can have different abilities to comply with the therapies and take daily therapies at home. And then also individual factors such as differences in comorbid conditions. This means just other non-leukemia health conditions that people have, such as high blood pressure, having had a stroke, other cancers, those kind of things. And then also differences in socioeconomic status, as well as differences in the amount of social support and family support that they have. And then finally, structural barriers, like people who have more of a cultural differences between themselves and their practitioners, as well as language barriers between themselves and their practitioners. And then finally, a lack of equal access to novel therapies like the newer ones and the trials that are coming out. So now we can start to think about which contribute most to outcome disparities and how might those be overcome. And the first thing I should note is that I had a lie of omission a few slides back. I purposefully didn't mention that this analysis looked at race-based outcomes, but it also used statistical techniques to kind of adjust for differences between the groups, such as the risk of their leukemia based on its mutations. And there are also things like their initial white blood cell count that we know has to do with the risk of their leukemia coming back and kind of a risk of a shorter survival. So what I showed in this not only accounts for kind of the treatment being the same for everybody, but also accounts for kind of those differences in biology potentially. So you can see that the differences, even when we accounted for some differences in biology, still remain different because of race and in this case, sex. This next study, which looks very complicated, and we don't have to talk a lot about the kind of details and minutia of that big nasty looking chart on the left. It does start to random or modernize kind of the things that I showed you in the last slide a bit by actually looking at specific mutations and how differences in mutations by self-identified race and ethnic group impacted survival. So this complex chart on the left basically shows the different mutation percentages across a large number of people who participated in AML trials. And the kind of bottom line of this is that there are some mutations, such as ones called WT1 and NPM1 that are outlined in red here, that were less frequently detected in Black patients. And there were others such as IDH2 and this PIK3CD mutations that were outlined in green that were more frequently detected in Black patients. But interestingly, even when they did statistical adjustments that basically accounted for these differences in mutations between different race ethnic groups, this survival analysis on the right demonstrated that Black race was independently predictive of poorer survival compared to white race, even when they kind of accounted for the differences in risk that come with these differences in mutations. And this graph is structured such that there's this line at 1, and things to the right of 1 mean that they're associated with poorer survival, and things to the left of 1 means that it's associated with improvements in survival. And so you can see that Black versus white with this dot over around the 1.5 means it's about a 50% higher likelihood of death for patients who are Black versus white. And as people get older, as their white count gets higher, and as they have this FLT or FLT3 mutation, but actually having this NPM1 mutation portends a better prognosis. So to kind of together, it all shows that African Americans, still when you're accounting for differences in mutations, have a poor prognosis, likely due to things like structural racism, although this doesn't particularly look into that too closely. It just accounts for these other biologic factors. So what might be some of the social determinants that do impact survival? This analysis was of patients in a Florida registry, and differences in survival were seen between African American and white patients here, with about a 26% increased risk of death for African American patients in this group, which was statistically significant, meaning that it was unlikely to be, the difference was unlikely to be due to chance. They also saw that there were these additional associations, meaning increases in the risk of death for people who were smokers, those from communities with higher poverty, and then those with Medicaid insurance. And while there weren't analyses performed here to test really the direct impact of these kind of socio-demographic factors and structural and social determinant of health factors on the difference between African Americans and white patients in this, there were higher levels of smoking, poverty, and Medicaid insurance among the African Americans in this population, which was suggestive that these factors were really impacting this number here. And in addition to the differences in treatment outcomes, there are also specific disparities related to bone marrow transplantation, which is of course a very important treatment option for people with AML. On the left is a chart that shows the relative difference in transplantation for African American patients compared to Caucasian patients from 2000 to 2010, with the percentages indicating the degree to which transplant was used less in African-American patients. This is the percentage overall for those who had a matched sibling donor and for those who had an unrelated donor. And on the right, you can see the use of transplantation using an unrelated donor only by race ethnic group in the period of 2005 to 2011 in red, and the period 2012 to 2017 in blue. And this shows that kind of looking between these two periods, the rates, or excuse me, the likelihood of undergoing one of these unrelated donor transplants increased for pretty much every group. As you can see, the blue is higher than the red for pretty much every group, but that overall it was still much lower for those who identified as white, Hispanic, or African. And this is largely, and especially compared to those who identified as European or European ancestry. And this is largely because unrelated donor banks have a large presence in Europe, especially Northern Europe, places like Germany and Sweden, as well as ones in the United States. So more patients share genetic ancestries and what are called HLA types, or kind of the things that need to be matched with those unrelated donors for this type of transplant. So these patients with European backgrounds are much more likely to be able to find a match in Germany or Sweden or those kind of places compared to people who are Hispanic or African, where there aren't large donor groups back in those countries as well. Importantly, however, I should note, while I'm not displaying data about it here, there are a bunch of newer approaches like a transplant that uses what's called post-transplant cyclophosphamide. And what that name and everything does is allows doctors to use donors that are not perfectly matched, and they also look to have similar outcomes to these matched donor transplants. So this, there's kind of early data on this, and we're hoping to see kind of a larger comparison that really shows that they're equivalent, which is kind of ongoing right now. But with these confirmatory studies, hopefully this may alleviate and ameliorate this difference in transplantation for patients from Hispanic and African backgrounds. One of the other factors impacting leukemia outcome disparities that's just starting to be explored, and that's a particular area of interest for me, is something that we have known about in solid tumors and multiple myeloma for some time, and these are disparities in clinical trial enrollment. And this is kind of an epidemiologic look, like a big US population-based look at acute leukemia and AML trials, reporting to kind of a central database called clinicaltrials.gov that you might have heard of, where we compared enrollment by race and ethnicity to how many people in each race ethnic group had AML nationally. And on the left in blue is a chart showing the odds that each of the groups listed on the left the odds that each of these groups were enrolled as often as a white patient with AML. And if they were the same, kind of the blue dots for these would sit at 1. If relatively fewer people were enrolled in the group, this would shift towards 0, which you can see happening for all these groups. And if they were kind of over-enrolled relative to how many people had the disease, these dots would be to the right of 1. And as you can see, Black patients were enrolled about 68% as often as white patients, Native American patients only about 30% as often, Asian patients about 75% often, and Hispanic patients about 80% as often. We're also interested in the impact of some government requirements that went into place at the end of the 2000s and really forced researchers and pharmaceutical companies to report these data more often. And so we compared enrollment between periods before and after these requirements went into place in this green chart here. And here we looked at how enrollment for each of these groups compared to itself between these two periods. So in this case, dots to the left of 1 means that these groups were actually enrolled less in this 2011 to 14 period compared to an earlier period. And anything to the right means that they were actually enrolled more. And unfortunately, as you can see, Black, Asian, and Hispanic patients were actually enrolled less over time as we've gotten closer to the present. And there, due to the small amount of Native American patients that were in this database, we couldn't accurately say what happened with this group. And kind of the final data-driven piece of information I'll talk about is a recent publication that looked at the impact of structural violence, or the harm a social structure does to people through systemic disadvantage on AML survival. And we don't have to go through kind of the large and small text in the table here, but the takeaway was that persons that were affected by structural disadvantage through community poverty, unemployment, and lower concentrations of education, as well as lower concentrations of high salary and professional workers, had lower rates of survival with AML, and that those factors were what actually drove the differences in the race and ethnic disparities in survival, more than their differences, kind of the risk of the biology of their AML. And so earlier we reviewed what some of the groups are that experience leukemia-related outcome disparities, what disparities they experience, and the degree and the scope of that disparity. These more recent data now look into what determinants or causes perpetuate these disparities, and these include, but are not limited to, insurance, poverty, treatment access, in trial enrollment, and some of those molecular and kind of cytogenetic differences, the differences in their disease biology. Now we're just beginning studies to look exactly how these factors lead to kind of downstream associations that we've seen, and this is being done in concert with different developments of interventions to reduce them. So this framework is just something I also wanted to introduce, really to show you how complex it is to intervene and kind of act and to improve different disparities that we see. And this is a framework from the National Institute on Minority Health and Health Disparities. And while I don't need to go through the whole figure, I just wanted to show you really these different levels of influence that all interact. And these are things that I've mentioned a little bit before, like biology, behavioral differences, physical and social environment, and then healthcare system domains of influence, as well as kind of where those things can act kind of at the individual level, the interpersonal level between you and your doctor, at the community level, and then at the society level. Kind of each of these interactions can be targeted either separately or together. And so I just wanted to show you kind of 3 examples of some of the actions that we're now trying to undertake to reduce these health-related disparities generally, and some AML disparities specifically. The first is the Leukemia Lymphoma Society, which has a trial support center for patients where they can call to identify and be navigated through trial enrollment. This is not specific to AML, where the immediacy of treatment that some people need make navigation to other sites, especially for trials, difficult, but it does offer a variety of support and information for those seeking, and provides kind of an extra resource for those not receiving care at institutions with a robust clinical trial portfolio. And you can kind of see these are the different domains and levels of influence that this intervention targets. This next one is a more kind of policy level one, and this is something called the Food and Drug Administration's Project Equity, which is run through their Office of Clinical Excellence and, Oncology Center of Excellence. And it's basically to ensure that the data submitted to the FDA for approval of oncology chemotherapies and other drugs kind of adequately reflects the different groups and demographics for patients that the drug is indicated for. And they're currently developing policy metrics to assess trial representativeness and work with companies developing new treatments to make sure that they enroll patients equitably and representatively, so that when the treatment comes out, they kind of know how it works in different groups, not only because there are some associations with those mutations, like I showed you before, but different abilities of people to kind of safely take the drugs at home and be able to come in and kind of have support that they need, both from the hospital as well as kind of from their social support. And finally, there's a set of interventions called provider performance feedback, which is one of the interventions I'm working on, which really provides clinicians and hospitals with kind of periodic, almost audits of their performance enrolling and treating patients from diverse communities compared to their peer institutions and peer clinicians. And this is basically because doctors are competitive people at heart, and we don't like to do worse than other people, and we like to kind of shoot to get an A on all of our tests. And so this really takes advantage of that and tries to show doctors how they're doing, kind of who they're not reaching, and what's happening when they're trying to enroll people from different backgrounds. This really just aims to also help them understand any unconscious bias or other structural issues that they or their clinical group has, and then we kind of help to work with them to provide training such as implicit bias training, or help them kind of access other resources for their patients and how they can improve access for underrepresented groups. And lastly, let's spend a couple minutes talking a little bit more specifically about why this matters for you and kind of what you can do during your care. First, some things that health professionals are doing to really help remediate these health disparities, in addition to the specific interventions that I mentioned. Kind of most generally, hospitals and providers are working to increase financial assistance and alternative payment methods aimed at improving equitable access to therapy, as well as to facilitate underrepresented community involvement in care and trials. They're also looking to kind of at their individual site and practice patterns, like I mentioned, to kind of objectively assess if they're treating and enrolling and caring for people in an unbiased manner and kind of how they can improve that for everyone. They're also reviewing their kind of day-to-day processes to make sure there's kind of cultural language appropriateness for their specific communities and their community groups, and understand how they prefer to be communicated with about different topics. And then finally, working with legislatures and government partners to increase awareness of local inequities. And while I don't think that the onus should be on patients to improve care equity, as they're already dealing with a very serious health issue, care at this point is inequitable, and there are things that you can do during your care to make sure that it's of the highest quality. The first is to make sure that you take advantage of all the local and online resources that you can, which if you're here, you likely are. But there are a variety of people in your care team, such as social workers, care coordinators, physical therapists, other people apart from the doctor and nurse or nurse practitioner or physician assistant that you're working with, that you can turn to for issues surrounding finances, social support, spiritual support. There's also organizations, HealthTree obviously being one of them, as well as other ones like I've mentioned, the Leukemia and Lymphoma Society and the American Cancer Society and the American Society of Hematology. Really do things like offer peer-to-peer support, financial support. Your institution, you can always look into seeing if they have different transportation and parking supports as well. The educational resources that HealthTree and these other organizations offer, also specific things like you saw in that Premier video about caregiver support, and then a lot of language preference appropriate information. Secondly, I always encourage people to seek a second opinion about their treatment and consider joining a clinical trial. This isn't always possible at AML when treatment might need to be given right away, but in some cases you do have that opportunity, and more institutions, especially during the pandemic, have been offering virtual second opinions that can also minimize any travel time and financial costs, as well as reduce infection risks. And with regard to clinical trials, there are many more treatments available for AML than there ever have been, and that's because of the incredible success of the medicines that have all been offered first in these clinical trials. And these trials are available for people at every stage of their disease. And like I said, there's great resources specifically on these different websites where you can learn more about what it means to participate, and also just hear about what clinical trials actually are, what it's like to participate, as well as answering some specific questions about common misconceptions that people can have about trials. And finally, while not directly related to your care, hearing the voice of the AML community is the most important thing for changing policies to make care more equitable. And again, I want to make sure people's focus is on their health, but if they're so inclined, or if they have family or friends who are asking what else they can do to help, advocating for AML research and health disparities research locally and legislatively really does go a long way. And with that, I think I am coming to the end. So I'm happy to take questions, and I can stop sharing my screen.
Thank you so much, Dr. Hantel. That was really, really informative. I know I learned so much in you sharing your work, and I'm sure our audience did too. Let me go ahead and share my screen back here, and we can get to our discussion portion. So as a reminder, you can ask a question or make a comment by typing it in the chat box, or by raising your hand if you'd like to verbally speak to the group. If you do want to raise your hand, once you're called on, you can then unmute yourself. So let me check our chat here and see if I see anything coming in. I'll keep it open. But maybe while things roll in, I can start off with a question that came up for me. You described very well a lot of contributing factors, whether that's biological, socioeconomic status, transplant factors, lower enrollment in trials. And I'm wondering how you prioritize these factors in determining what interventions to start with. In your work, have you found that maybe one contributes to disparities more than others, or is it a multifaceted approach when you create these interventions?
Yeah, so it's really more the latter. So like you saw in that big complex table where there were kind of all those different levels of influence and all of those different domains, such as like the individual level and the health system level and those kind of things. The tack that people have found most effective is really developing interventions that target multiple things at once and kind of do so in a complementary way. So one of the projects that we're working on kind of goes after, you know, 3 different levels at once. So we are kind of developing and rolling out an intervention to kind of educate patients when they're first diagnosed and sitting in the hospital and deciding on whether or not they would like to participate in a clinical trial if it's appropriate for them. And so we'll kind of give them different information about the trial and kind of educate them about their, you know, new diagnosis as well, and offer them kind of supports. And at the same time, we're also going to be providing kind of like that feedback that I mentioned to the providers. So that's kind of a second level on there, and kind of saying, who are you enrolling over time and kind of how is that going? And then on top of that, we're also doing something where we're actually looking at the trials themselves and reviewing the different criteria that people need to meet to be able to enroll in the trial, because sometimes it's been seen in other cancers that those criteria have actually furthered the disparities in terms of who's allowed to even go on to a trial. And so we're kind of going to be looking at those to try and say, hey, this one really is discriminatory against this group or this group, and would you be able to remove it or kind of make it less stringent, those different things. So kind of doing that all at once to be able to go after it. There are also very kind of targeted interventions, especially for specific cultural groups. There are partnerships that some hospitals will have with indigenous populations, because those might be more present at different locations. One is Roswell Park up in upstate New York has a large Native American population, and they have a specific indigenous health connection that they're working on to be able to increase the outcomes and enrollment for those patients. So it's really something where you're trying to hit that sweet spot of making something broad enough where you can kind of allow it to reach a large number of people and be able to influence their care, but also specific enough that it actually affects different people. So it's a tough question, and it also has a lot of things that are outside doctors or patient specific control, like a lot of those policy decisions that I was mentioning. And so we try and use things like specific interventions, as well as those other data analyses that I was showing you, to be able to kind of influence policymakers to make changes at those larger levels.
Yeah, great. Okay, I see some things coming up in the chat here. So someone's asking what can be done to diversify the stem cell donor bank to ensure that minorities can access this life-saving treatment?
That's a great question. So there are a couple things going on. The first thing that I had mentioned a little bit in the slideshow was actually changes in the way that the stem cell conditioning and the particular types of stem cells that are given. So there's different donors that people can have for stem cells. Some of them are, matched siblings. Some of them are these unrelated donors that are usually matched. And then there's other combinations of unmatched donors with things like umbilical cord blood. And initially, there were different risks with some of those, and some of them were kind of either less likely to work to keep the leukemia away, or had more side effects apart from the leukemia that comes with the actual transplant itself. But there are some newer techniques with what's called this post-transplant cyclophosphamide, where they can give unmatched donors, so they don't have to have those same characteristics that are usually related to somebody's genetic ancestry to be able to give them these unmatched cells that will still work both to keep leukemia away and not come with excess other risks. And so it is starting to open up transplant to a lot more people who were unable to get it, usually due to their minority background and having genetics for people that didn't have a lot of donor matches because of that. On top of that, specific societies like the National Marrow Donor Program and the Leukemia Lymphoma Society and the American Society for Hematology are having targeted efforts right now to do outreach into underserved communities with respect to those donor banks, to be able to recruit more people in the community from those groups who are not in the banks right now, to be able to have more of those people available as donors. So it's not a quick process for that. We're hopeful though that both the that post-transplant cyclophosphamide treatment that I mentioned, as well as those increases are making headway. I will say that the trial that the post-transplant cyclophosphamide was given in actually had 44% minority enrollment, which was almost double what the usual amount is, and on par, if not greater than the amount of people who have the diseases who from those minority groups who would have gone to transplant. So they were really able to provide that to a large number of people from usually underserved minorities. And so that just, I think, just evidence of the fact that there's a great demand, obviously, and a great need there, and that it was very likely to not only work, but kind of do so with less risk from the transplant as well.
Great. Another question's come up asking, in your opinion, are the racial disparities in academic or specialized centers equal or less frequent than in local centers?
They are both less and more. So it depends on the specific disparity that we're talking about. Academic centers, especially those National Cancer Institute designated comprehensive cancer centers where a lot of the research and the trials go on, have a larger disparity in people from underrepresented minorities getting to those centers, getting access to those centers. This has been shown both by work that we've done that is being published soon, as well as some other work that's come out of mainly California. But when people actually get to the centers, then they actually, it actually looks like African Americans and Hispanic patients at the centers might have as good, if not better, survival outcomes. I think it also that is changing somewhat in terms of what's happening to people when they get to the centers, because there's been all these new treatments, and it's also that these centers are the first ones that generally are comfortable using these novel therapies. Like you might have heard of venetoclax, and there's other drugs that are coming out. And those are generally, first studied at the academic centers, so they're more comfortable using them when they come out initially. And so it might be that those patients were getting earlier access, or kind of a greater proportion of them were getting access to them earlier on. But it is kind of one, disappointing that these large cancer centers, including the one that I'm at, which basically my life's work is to try and get that access improved, that they are having poorer access for these minority groups, both locally as well as nationally. But then once people are actually able to get here, that we can provide very good treatment, and it seems like ameliorate some of, or if not most, or all of the survival disparities. So I think that it's definitely an evolving issue, and it really also depends on the particulars of somebody's tumor, and that those different mutations that and cytogenetic abnormalities that people can have definitely play a large role in any individual person's survival, but that also getting a second opinion, especially from a center that has a lot of trials, really goes a long way, and may potentially improve an individual's survival. So,
great.
Yeah.
Nothing else I see in the chat, but I'll give it a few seconds if anybody would like to come off mute. Don't worry about raising your hand. We're a small group. So if you'd like to make any comments, feel free.
Hi, Dr. Hantel.
Oh,
You sort of touched on this a little bit, I think, but if you are a minority and you're diagnosed with AML and maybe you don't have access to larger treatment centers, I think you touched on it by saying, get a second opinion. But if you're just diagnosed, are there some sort of basic advice, guidelines that you could give, to someone who is just diagnosed, who might be going into this? Because not to mention that with AML, it's typically something, you have to make quick decisions often.
yeah, no, that's a great point. It's definitely to some extent an area of unmet need in terms of getting everybody a lot of information that's digestible, because that period is so fraught. I mean, even just hearing that you have leukemia is, you kind of like block out everything else in your mind. It's really hard to just process information. There's been a lot of studies showing that. And so getting people information in a way that they can process it and really understand what's going on, much less understand things about clinical trials or their treatment options and everything. I think no matter who you are, it's best to have family members or other supports, if you have them, to be with you, because they are there to kind of be your second set of eyes and ears and really help you digest that information, take notes, understand that. I'd say for anybody, but especially people from underserved backgrounds where there may be unconscious bias on the parts of the providers or the care team who are most likely trying to do their best, but everybody kind of has their background, is that, having people there to advocate for you because you are likely not feeling well is a big thing. Having people taking notes, kind of helping you do that research and kind of going to the different sites like HealthTree, going to Leukemia and Lymphoma Society that has very specific evidence-based kind of lay language information, both about what leukemia is, what the symptoms are, what the treatments are, what the expectations are, what the options are, all of those kind of things they lay out very nicely. And we can definitely send those links out like Katie said before. But I think that is probably the biggest thing that you can do, is just to really be able to work with your family and your support system to understand that. And I agree that the first diagnosis can be nowadays, because more people are getting more healthcare in general. We do see more people that are diagnosed potentially less sick, although during COVID that has kind of gone a little bit backwards. But we are seeing more patients who are feeling a little bit better and may have more time to kind of understand their disease and potentially get a second opinion. And sometimes if unfortunately patients have a relapse of their leukemia after treatment, oftentimes they do have more time to really kind of understand the clinical trials and options for treatment, because at that point they've already kind of known about their leukemia and digested that information, that at those points, kind of going on to HealthTree's website, going on to the Leukemia and Lymphoma Society, where they have the patient navigation for clinical trials. Those things are excellent resources, and they do have it in different languages as well. I know at least Leukemia and Lymphoma Society and the American Cancer Society have multilingual information packages and everything else for people to be able to learn both about the disease as well as clinical trial information. And so I would really suggest that they or their caregivers do that. Or, the other thing is that they don't have to do it all themselves. I think they should be asking their providers to really make sure that they offer that information as well, because there are a bunch of specifics hospital to hospital about, things like what transportation and kind of things for caregivers that they have, what other social supports they have, because we deal with people who have this disease every day, but when somebody gets it, it's the first time they've had it. They don't know what's going on. A lot of them have otherwise been healthy, even if they're older adults and haven't been to the medical or haven't been to the hospital a lot and don't really know the medical system. And so even just getting to know that is kind of a whole full-time job in itself, much less having leukemia. So I think people really need to advocate and kind of ask the doctor, ask the nurse practitioner, ask the physician assistant to say, give me what resources you have, give me the information sheets. What do patients who are like me usually turn to is another thing, and a good question to ask, because sometimes there are specific resources for people from different cultural backgrounds too, especially when those are there are more people like that in the local community. Like I mentioned, that like indigenous program for patients from Native American tribes at Roswell Park, and other similar things that other institutions have around. So I think those were probably be the most important things that I would say. I know that was a long answer and a little bit
No, that was
rambling, but I
great.
think there's kind of a lot of
Thank
things
you.
there.
Very much.
Yeah, really great. A comment here saying this was very interesting. Thank you. Happy to have you here, Sophie, and listening in. I'll give a few more seconds if anyone wants to pop off on mute, and we probably have time for one more question or comment from anybody.
I just had one more quick follow-up.
Sure.
Do you find that in today that this is an area that people are aware of in your setting on your side, or that you're sort of alone kind of doing this work over here on your own, and that this needs to be brought to light much more?
I think it is both being more recognized, but that there's also a long way to go. And I think it also depends on, what part of the country and what type of hospital you're talking about. I definitely have been asked a lot more to do a lot more outreach, both in terms of persons diagnosed with AML, as well as physician groups who would like to know more about race ethnic disparities and health equity and what can be done specifically for acute leukemias such as AML, as well as even pharmaceutical and industry partners who want to know kind of what they can do to both make access more ready for these, for a lot of these groups who have been historically underserved or disadvantaged, as well as how they can make sure that their upcoming and ongoing trials are more representative of the people diagnosed with them. So I think the interest is definitely there kind of at all of these different levels, but to the extent that it's really permeating, I think we still have a long way to go. I think it's still a lot more of the people who are kind of personally interested in it that are reaching out and asking me about it. But I definitely know that among the leukemia doctor and healthcare professional community, even in the past year, there's been a lot more visibility for this issue, and that there was kind of a anti-racism studio and different things at our big annual American Society of Hematology meeting that I helped run, and a lot of more research articles on it too. So I think it's kind of groundswell that's growing. But it's still a small community, and we're hoping to kind of share it with more people and get more answers to these pressing issues.
Yeah, and to piggyback off of that a little bit, I know this is probably not a short answer as we wrap up, but just thinking along the lines of the major gaps that really aren't being addressed right now that you're noticing, and us as a nonprofit, HealthTree, or even other nonprofits in the blood cancer space. I'm curious, you kind of mentioned a little bit about advocacy work, but like us and our AML community that we're building, are there any places for us to start really? What would that advocacy initial steps look like?
Yeah, so in terms of the like legislative advocacy and those kind of things, there are definitely specific, kind of bills coming before Congress, as well as a lot more on the state and local level that's being done. And in terms of how best to get involved, I've done most of my advocacy work through the American Society of Hematology that's like located in DC, kind of right by the Capitol and everything. And they do a lot of work on behalf of patients with AML to really make sure that, there's research funding, as well as funding support for patients who are going through treatment and after treatment, as well as for their families and communities. And so from that standpoint, I think the places, there's a lot of places to start. I would say that some of the places that I feel like I hear a lot about are getting kind of multicultural and language appropriate information to patients, especially in kind of that early diagnosis period, in a way that's digestible and kind of that their family is able to access, and kind of offering that kind of window of support in those first days. Because I think a lot of the disparities work that's been done so far is in other cancers, and those cancers, especially solid tumors, you get diagnosed with a biopsy, a couple of weeks later you see the doctor, you might have a surgery, you know, it's very spaced out over weeks or months. AML, it's like diagnosis, treatment. And so having that window, you need to really make things as crystal clear as possible for a very diverse set of people. And so doing that in a way that's, you know, digestible and culturally appropriate, language appropriate, is definitely something that's needed. I think we also, you know, are starting to study what the best techniques are for that, you know, just putting that information out there without actually seeing, is it effective, what can be made more effective, what's actually needed, what's not needed, is kind of a way that we're thinking about it on the research side. And so I think it's both a kind of a partnership that I think needs to maybe happen more between us on the academic side and people on the patient community advocacy side too.
Well, maybe we can talk a bit more
Yeah.
about involvement to help out. I think it's really important. Okay, a little bit over time. Sorry to keep you,
Sorry.
but I just want to say thank you so much. It's my hope, and I'm sure so many others here, that your work will really lead to some significant policy and practice improvements to help address these diversity and disparity issues for everyone with AML. A few announcements before we go. I'd like to mention we have several adult AML chapter meetings scheduled for April. On April 5th, HealthTree's financial manager, Diana Valentine, will join us, along with our myeloma division, to complete part 2 of her financial workshop series. In this series, she'll walk us through important financial documents and provide more advice to help us navigate the expenses that come along with a blood cancer diagnosis. On April 11th, we have 2 registered dietitians from the Mayo Clinic coming to speak with us on the topic of nutrition from diagnosis through transplant. And on April 21st, we will have an exciting discussion about the power of using reflective journaling and creativity to support your own personal recovery and growth. Our speakers for this event will also reveal that they're inviting the HealthTree community to participate in a free 8-week workshop over the summer. So you'll want to attend this event to get more details. You can find the registration pages for these events and others by visiting healthtree.org/AML/community/events. And I have one more announcement before I let you go. Really exciting. We launched a new fitness tracking app called HealthTree Moves, where you can join challenges, track your activity, engage with others in the community, and win prizes. We invite you to join us during April for our very first activity challenge through the app. Our goal with Active for AML Challenge is to start or continue healthy habits while building community and bringing awareness to AML. The focus for this challenge is on being active where you are, wherever you are in your journey, while valuing the importance of sleep and hydration, all while realizing how making small changes to your habits can make a difference every day. So the use of this app and the Active for AML Challenge in April is open to all AML patients and their caregivers. The challenge starts in 2 days on April 1st, and we will have a collective goal of 100,000 minutes of activity for the month. So you can download the app from either the Google Play or the Apple Store, and look for the icon I have here on the slide. You can also learn more at healthtree.org/move. So I really hope to see each of you there participating with us. Once again, thank you to our HealthTree community for AML sponsors, Bristol Myers Squibb, Amgen, Genentech, AbbVie, and Jazz Pharmaceuticals. And thank you all for helping us to build a strong HealthTree community for AML. I appreciate you each for being here, and I can't wait to see you again during our April events and during our Active for AML Challenge starting this Friday.